It's really inspiring. Even if you go to one state and just look at what they're doing, if you have time, or talk to people here that have been involved, whether it's New Jersey, Massachusetts, Montana, Vermont, et cetera. It's really inspiring. So, the next person we want to invite up is Alex Young. As you know, we had a paper written, I think it was in 2016, on clozapine and on the underutilization of clozapine. It really started moving the interest in increasing the use of clozapine around the United States. And we started having connections with people who were very much interested in clozapine. As a next step, and Alex is going to talk about this, the SAMHSA has been promoting a product that increases the knowledge base about clozapine and increases the availability of information through a website that we think will really make a difference going forward. And Alex is going to talk about both clozapine and the SMI advisor. So, Alex.
Thanks, Brian. People can hear me? So, and thanks for having me. And I don't know if Brian mentioned this is the last talk of the afternoon, too. So I guess my first goal is to keep your attention for the next half an hour. But I have two other goals. And so I'm going to talk about clozapine. So clozapine is our most effective medication for schizophrenia, for serious mental illness. It's also one of our most underused. So I'm going to talk to you a little about clozapine in terms of what it is, why we should be using more of it, and how that might be possible. And then I'm also going to talk about, as Brian said, SMI Advisor, which is a new SAMHSA project. It's just had its 1-year birthday, but we're really rolling at this point in time. This is a project to focus on improving care for serious mental illness. So this is part of the new SAMHSA focus on serious mental illness and what we can do to really make services better. It has a lot of educational resources in addition to resources about clozapine we're talking about. My goal here is to convince you that SMI Advisor can be useful to you, and that there are things here that you can make use of in the SMI Advisor project. So you can tell me if that's right or not, I guess, at the end. So in terms of clozapine, so clozapine is all about treatment resistance. So as I think people know, schizophrenia is sort of like our modal serious mental illness. It's one of our most common disorders seen at public mental health clinics. It's also a very challenging disorder to treat. It can be very disabling when not appropriately treated, not treated well, but people also can do very well with the illness when there's a combination of effective medication and effective rehabilitation services, like, for instance, you just saw in the last talk. But the problem is that it can be resistant to treatment and medications. And so that's where clozapine comes in. And here you see some of the problems with treatment resistance. It causes substantial problems with quality of life. People who have treatment-resistant schizophrenia have a substantially worse quality of life, much more expensive, high rates of suicidal ideation, substance abuse, smoking, and so forth. So this is sort of a complicated slide, but the question here is how common is treatment resistance? This is treatment response in people with new schizophrenia over 3 years. These are people that are in treatment, and basically what this shows is that only about a quarter of them get completely better in terms of remission, in terms of functioning and symptoms. However, around 2/3 do substantially improve or get much better in terms of symptoms and/or functioning. But that leaves a third who don't. And that's what the focus of schizophrenia, that's the focus of clozapine and schizophrenia comes in. This is a slide that talks about the effectiveness of medications, antipsychotic medications, in usual practice. So this is not, in research studies or laboratory or something. This is actually from a nation, this is from Sweden, but this is all their patients with schizophrenia, and looking at how effective their antipsychotic medications are. And you can see the #1 effective antipsychotic medication on this list, which is the one on the top, is clozapine. And this is effectiveness in terms of improving outcomes, preventing poor outcomes. The second one is polypharmacy, which is another talk. And then the next about 10 are long-acting injectable medications, which is also another medication class that we use way too little of in the United States and is used much more in other countries in addition to clozapine. So where does clozapine fit in? Treatment guidelines for schizophrenia say that it should be used in people with treatment-resistant schizophrenia or people who are at risk for suicide or risk for aggressive behavior. It's been shown to be effective in each of those folks, and that's, of course, a large population. So it's a lot of people. So the question is, where are we at? And what you can see here is two graphics. One is clozapine rates of use, which is the percent, and one is the use by state in the United States. So in terms of clozapine use, you can see that some countries are using it in about 1/3 of their patients with schizophrenia, which is about the same size of the population that's treatment resistant, so is not a unreasonable benchmark. Australia, 35% of their patients are on it. China, 30%. Some countries in Europe are also doing very well, England, Germany. United States, 4%. Which is a very low number, down there with a bunch of other countries, but is really, and that's actually substantially lower than we've been in the past, and it's a problem because it means that a lot of people are not benefiting. I can tell you as a psychiatrist that some of my most rewarding treatment experiences, if not most of them, have been using clozapine. Because I will take people with schizophrenia who are doing poorly, where their life is going really badly, and I take this medication, and about half of them do substantially better. So this is like produces a major life change, very rewarding experience as a psychiatrist, which I am, and in terms of the treatment. So 4% is a very low number. You can see the states there in the colors. The purple is good. The other's not so good. And so the purple is relatively good, 10% or over on clozapine. So if you're in Washington, Maine, Vermont, Connecticut, South Dakota, or Colorado, I think I have those right. I may be missing one of them. Anyway, there'll be a quiz later. You're doing okay from a state perspective. Other states, not so much. And so the question is, what can we do about improving services for people with serious mental illness broadly? And then clozapine in specific as one example of a service that's very effective that people aren't making use of. This is where the SAMHSA CSS SMI or SMI Advisor project comes in. So this is a multi-year effort from SAMHSA to provide resources to improve services for people with serious mental illness, improve their functional and recovery outcomes. It's a multidisciplinary effort. We have involvement from families. Terry Brister's in the back from NAMI. We have involvement from nurses, from peers, from Mental Health America. One of their, Patrick, one of their peer leads is on our core team. We have a psychology. So we have a diverse effort to try and improve service provision. The aims of the projects are these, is to provide education on evidence-based practice, consultation to clinicians about specific problems they're facing in their practice or challenges, ongoing needs assessment, and technology and implementation to support care. I'm going to show you just a few examples of each of these. This is our website. This is sort of like the front door of the project. I encourage you to check it out. We've had, I don't know how many, 40,000 more visitors to the site so far. It lights up really well in Google. We have a really good web development team that's won some awards for this project, a really good marketing team, which is, I recommend it. Social marketing group has been very helpful. So it's www.smiadvisor.org. I also have some handouts up here. If you just type SMI Advisor into Google, it'll show right up. And there are resources here for clinicians, patients, and family members. So, and you'll see that there's, right here on the front page, there's a portal if you're a clinician or provider, a patient or family member. So we start with, there's a lot of education available on the project. Education for multiple different disciplines. We have 23 courses so far on the project. We have numerous webinars. We offer continuing education. We offer continuing education currently for physicians, for nurses and psychologists, and we're working on bringing on board social workers. It turns out to be one of the more challenging CE to do, but we're going to do it. And these are all free. They're free, they're on demand, they're recent, they're focused on skills that are of use for clinicians, patients, and families around serious mental illness, so I encourage you to check them out and spread the word. These are just some of the topics of the webinars: technology, telehealth, that sort of thing. Psychopharmacology, for example, clozapine, recovery, peer support services, and then access to care. We also have a robust knowledge base. You can actually ask questions. Or people can go on the site, ask questions. We have a chat bot that I'm going to show you. We have an app, smartphone app that's going to be out imminently, sometime in the next month or two, hopefully. And we have a lot of answers to questions in a knowledge base. We've also curated what I think is probably most of the best information that's out there about serious mental illness. So if you type in, a lot of resources. And NASHP has played a big role in working with us with identifying those. So those are available through here. You can ask questions. You can search for things in the website. There's a lot of information there. And I would point out this is also for patients and families. We've worked hard to make sure that we have resources that are similar across both groups, working from the assumption that patients and families these days are pretty informed consumers of information, and that we have to provide a high level of information for those groups to offer something meaningful for them. We're also very interested in engagement. So this is something that we could also use your help with. We want to really be engaged with clinicians on the front line as they're working with people with serious mental illness and as they're asking questions about what they can do and what's effective. We have a chat bot currently on our website. You're welcome to use it. I would say it's sort of like a high school level chat bot at this point in time. We're working on making smarter chatbots. I know I personally find them a little frustrating, but it is a way of searching things on the website. It does provide information. If you type stuff in there, it will do its best to get you to the information that you're looking for on the website. Clinicians can request a consultation, free, confidential consultation with any question about recovery, rehabilitation, peer services, family services, psychopharmacology, and get an answer within 24 hours. And so that's something that's available through the website. We do have a booth, by the way, in the vendor area. You can also look for that there. This is Salesforce. So, and there's a reason why Salesforce has some enormous buildings in San Francisco and stuff, and it's worth a gigantic amount of money. They do very good with data analytics. And so we've managed to build a lot of really good data analytics. We're actually going to make this available publicly through the website. But we're able to track very closely who's using what they're interested in, where they're working. We have people in all 50 states that have started to engage with this. So we do really work hard to make sure that we're providing useful services to people nationally, as this is a national project. And by the way, you're welcome to contact me as well. Alexander Young, I'm at UCLA, using my email there or through this website. If there's anything I can help with. So I want to talk a little about clozapine. So clozapine, again, we're at 4% in the United States, so really, really low. The question has been, this is one of the efforts of SMI Advisor. We want to get more clozapine going. We want to figure out how to make it possible. Our first step in this is we've established a Clozapine Center of Excellence in partnership with NASMHPD and with Brian and the other folks in NASMHPD to establish basically a working group of folks around the country, including family members, clinicians, experts, and so forth in clozapine, and to establish resources and to provide technical assistance consultation to figure out what we can do to help folks use more clozapine. It's available. We have a good website, which is on the slide here, but basically if you type in SMI Advisor clozapine, you'll see it. We have a lot of resources curated there in terms of education. We also have worked very hard to come up with clinical tips. So clozapine, I didn't mention, we're sort of in the unfortunate position in psychiatry that our most effective medications are also usually our most toxic or most difficult to use, which I guess is good because then there's always a role for psychiatrists, because if really effective medications really easy to use, there'd be no reason for psychiatrists. You wouldn't need us. Anyone could use them, or you can get them over the counter. But that's not the case. So clozapine is complicated. It is, when used effectively and appropriately, is safe as every other medication that we have, but it's harder to use. It requires regular blood test monitoring, has a different set of side effects from other medications. Patients, in my experience, do like the medication, and they understand that it's something that requires some more monitoring as they're using it to make sure that it's working, but they like the fact that it works, first of all, and also that it actually, the side effects, while they need to be carefully done, are in most patients always manageable. You can also you and or your psychiatrist or whoever's interested can sign up for our listserv. We have a clinician listserv on clozapine. We've got a whole range of online clinical activities, webinars, and so forth that can help folks who are thinking about clozapine for family members, for clinics, for clinicians. We've also put together a range of clinical tips. So because it's different and more complicated to use, there's a learning curve for using it, and need to, as a prescriber, as a clinician, and this can be a psychiatrist or a nurse practitioner, for example, you need to learn about the side effects and how to manage them. We've done all that on the website. We have a whole long list of clinical tips, which basically is how you manage these possible side effects, how you do the screening, that sort of thing. We have frequently asked questions, and we have guidelines. Now, in terms of where we're at with the Clozapine Center, our goal now is to try and identify people around the country who want to make more use of clozapine. So we're interested in working with clinics, clinicians, counties, states, people that would like to see more clozapine used in patients who could benefit from it. And these can also be people working in state hospitals, jails, prisons. It can be in facilities, community-based facilities, academic facilities, anywhere. And so we're working now to engage with folks around the country to be able to then provide them with technical assistance and consultation to allow them to use this medication, knowing that it is a very rewarding medication for use for clinicians and patients, but it's also something that has to be intentionally done, and it's more challenging. So we provide consultation and mentorship, and people can get this in a couple ways. They can place a consult using our website, and we'll get that, and then we can engage with them to help provide consultation, technical assistance, and make it happen. I would also say that that same thing applies to other services for serious mental illness. So if you have a clinic that wants to get more, for example, peer services going, we have experts in peer services in terms of how you structure them, how you start them, what people can do, what the, in a sense, the guidelines or the protocols are, what kind of the job descriptions, that kind of thing. We can provide that. If your center wants to get more family services going, we can do that. If you want to get more rehabilitation, psychological services, like what you saw in the last talk, we can help with that. And the way at that is basically via our website, asking for consultation around a specific area, and then we can get in touch and work together on this. One of the areas that we're focusing on over the next year are learning collaboratives, so virtual learning collaboratives. So the idea here is, and this is something that is, I think, an exciting approach to learning, education, and training. And something that's actually relatively recent. It's a collaborative environment. It's a bit like a class or a course, but it's done by the internet via websites, online forums, webinars, chat, call-in hours, that kind of thing. So the idea is that we get together a group of people around a specific topic, provide education, resources, and help them as they step forward with implementing a practice or getting more of something going that they want. We have a number of, we're going to be standing up like a dozen of these collaboratives or more over the next 6 months. Again, people are going to be able to apply through our website, as I'll show you. Now these are, and we have we're going to have collaboratives on homelessness, on peer services, on measurement-based care, and a number of different things, and you can see them online. We also have collaboratives specifically designed for nurses who want to learn more about psychiatry or mental health, so on and so forth. You'll be able to sign up. I'll show you a link where people can sign up if they have more interest in learning about those. Those will also be advertised through our website and through other channels. We have a specific clozapine collaborative that's starting that I'm going to be leading along with some other folks that use a fair amount of clozapine. And this one is going to be for physicians, nurse practitioners, or medical directors. Basically people that want to get more clozapine going. And this is going to be a 12-week collaborative. People sign up for 1 hour of work a week. And the work involves a number of different things. It can be some webinars, it can be discussion, consultation. It can be work in their clinic or talking with patients, that kind of thing. There's a variety of things that go on. It's a structured curriculum, and it's something that, again, we're going to be started. And it's going to include a live interaction. So this is in terms of the collaborative, again, 12-week online course, a number of different topics. Other topics, for example, include medical care, integrating primary care and mental health services, or telehealth, telemental health is going to be a topic. Apps, that's use of telepsychiatry, telemental health services. This offers CME. Services, CME, which is applicable both for physicians and for also most nurse practitioners are able to accept CME, at least for half of their hours. And so encourage you to think about this. And if you can, the link here is to sign up for more information, smiadvisor.org/learning collaboratives. I also have some handouts here. And so I'd encourage people there are folks who you think might be interested in getting more of any of these things going. We would like to be of help. These, again, they're free. And they provide a learning community of people working together. And we've had a lot of success with these. And even so, that's such that the communities often sort of stick together after the collaboratives end, because it's a real opportunity to network with folks around specific practices and getting specific things going. So I want to thank you for your time and attention and sticking around until the end of the afternoon. And I'm happy to take any questions.
I had a question.
Yeah.
Because we have an international group, can people from other countries get onto the website? Would they be able to benefit from the website?
Yes, it is possible to get on the website and sign up for things internationally. There's some things like it asks you for, it's sponsored by SAMHS, so it's US SAMHS, so it's specifically designed for US folks, but we do have actually a number of folks internationally who have signed up, and there's a lot of interest internationally. There are some things that might ask you for a zip code or something. You have to make up a 5-digit zip code. If you're from New Zealand or something, you may not have zip codes, but beyond that, yeah, absolutely, sure. And am I keeping everyone from dinner, or do we? All right.
Well, thank you.
All right. Okay. Thank you.
Oh, sorry.
Yeah, please. Hi.
Hi, I'm Christine M.S.H. and I'm from the UK, and mental health social worker. I was based in specialist mental health centre for deaf people, and I know Clozapine was used with people who were treatment resistant, and from that I realised it's used more in the UK. But my question is, why do you think it's not used more in the US compared to other countries?
Yeah. So in turn, the question is, why is it not used as much in the US as some other countries? And I think it's a variety of things. First of all, it is more complicated to use than the other medications. A lot of our people here are not trained in how to use it, and it does require regular blood tests. There are some countries in that list, such as China, that don't do a lot of blood testing. And the blood testing was required is because there's about 1% rate of people who have a serious allergy that can be fatal if not detected. So that's what the blood test is for. Other countries seem to have a bit of a lower concern about that. The other thing is that this country, we're also, fair amount of what we use is what's marketed. And there's been a lot of the Clozapine has been sort of taken away by extensive pharma marketing of other medications, which are not as effective, but are newer and are somewhat easier to use. I would say the other thing is that we just, it requires somewhat more effort. So people have to, the monitoring basically requires weekly patient encounters for the first 6 months, and then every 2 weeks, and then every year, meaning they often come to like the clinic, or there's some kind of communication with them around the monitoring. And so it's somewhat more expensive to use than the other things. But we're hoping to, we can learn, hopefully we can learn some things from other countries. The UK is doing better than we're doing, and some other countries as well, and hopefully we can make a difference with it. Yes?
How much is
how much is the fear of litigation a factor, and what about the use of clozapine in adolescents?
Right, so 2 questions. What about litigation? The bane of United States society, and the second one is adolescents. So I'll take the easy one first. Adolescents, it works great in adolescents, and it's equally as well as adults over 18, and so definitely is indicated for people with treatment-refractory illness in adolescents. And it's a good idea to, of course, the earlier you can intervene with people with schizophrenia and get their symptoms controlled, the more they can develop, and in terms of their recovery and so forth. And it's nice if folks can not go for their entire adolescence with, a severe treatment-refractory psychotic illness, for example. In terms of litigation, I think we have a fairly strict regulatory environment around clozapine in this country, a REMS system. That's driven by pharma, actually, not by clinicians who don't like it. And the reason pharma does that, I think, is largely around litigation. So indirectly through big pharma, they're concerned about litigation, and so they put a lot of limits on the medication and make it hard to use. All I can speak to you as a clinician is that it doesn't concern me. It doesn't, I don't get concerned about litigation when I'm using this medication. You're working closely with patients. When you're working closely with patients, it's as safe as other medications. And we're dealing with people with very severe illnesses and very difficult lives and very poor outcomes to begin with. And so, it's not something that stops me. I can't speak for all psychiatrists, I guess, but I don't know. It's just it's not a concern for me.
Okay, well, thank you.
All right, thanks.
So thank you very much, and as it says, you have to go eat alone. And we will see you tomorrow. Thank you very much.